Well, I am just delighted to be here to talk with all of you. This topic of caring for the caregiver is near and dear to my heart. As care providers for older adults, we know that this is always an important topic to talk about, but perhaps never more important than during a pandemic that disproportionately affects vulnerable older adults and one in which we find ourselves in these days. And while this talk won't focus on COVID-19 in particular, I'll mention it quite a bit since it is indeed constantly on our minds. And I'll speak directly to caregiving in the time of COVID later on in the presentation. So Barb's already stole my thunder. You know who I am already. And my academic interest in interprofessional education and geriatrics workforce issues are, I think, why I was invited to come talk to you all today and why I'm extremely honored to be doing so. And also, I am just as enthusiastic as Barb seems about the age-friendly 4Ms framework. This, you really see that picture in the top here, the beacon of light. You really just can't go wrong when you focus care of older adults around the 4Ms, leading, as she said, with what matters most and considering mobility, mentation, and medications. And it's obvious to think about the caregiving of an older adult, particularly one with dementia, to think about these 4Ms as it pertains to the care recipient, but I also want you all to think about the 4Ms as it pertains to the caregiver, him or herself. Think about what matters to the caregiver. Have they planned themselves about their care planning? Think about mobility, medication, and mentation issues that affect the caregiver. So we'll be coming back to this throughout the talk. And just remember, you cannot go wrong if you focus on the 4Ms in care of older adults. And I'm really actually delighted to share with you all that I, starting in July, will begin a year-long fellowship with the John A. Hartford Foundation Age-Friendly Health Systems to help implement the 4Ms and the high-quality care that can follow into our organization at Swedish and our larger parent organization of Providence. So I'm really excited about that. And so caregiving, as I said, is personal to me. The woman you see on the left is my dear Grandma Ann. She's standing with my Grandpa Morris. And some would say that Grandma Ann had a difficult life filled with adversity. And in fact, she did. She lost a husband before my Grandpa Morris, very young, to brain cancer. And then my Grandpa Morris died in his late 40s of a heart attack. And after which she raised my mom and my mom's two brothers as a single mom. And then in her 50s, developed Parkinson's disease, which is younger than a normal age. And pretty soon after my parents, you can see them there in the middle, got married, my Grandma Ann moved in with them, and thus she was a part of my nuclear family growing up my entire childhood. I witnessed the caregiving of not just my mom, her daughter, but my dad, her son-in-law. And I saw the challenges that came with caregiving, the real challenges, but I also saw what having this person in my home meant to me, and how she really brought us together as a family, helped us focus on the importance of family in our life, and helped us really appreciate our health as well. And as my grandmother's Parkinson's progressed, she also developed dementia. And I think really what the message that I want to share to you is how incredibly grateful I am for the act of caregiving that my mom and dad gave to my Grandma Ann, because there is absolutely no doubt in my mind that is the reason that I went on to a profession in medicine, to a profession caring for older adults, and is absolutely one of the reasons that I stand here talking to you today. In honor of Grandma Ann, despite her challenges in her life, she was an extremely positive person, and when she would go outside on a sunny day, she would say, "It's great to be alive. It's a great to be alive day." And I ask you, in honor of Grandma Ann, The next time you go outside and it's sunny out there, think of her and say, it's great to be alive today. Moving on, these are our guiding questions. Okay, our guiding questions today. If I answer these, I have done a good job. They are, who are the dementia caregivers? What challenges do they face? And how do we support dementia caregivers throughout the caregiving journey? First, who are the dementia caregivers? We'll talk about definitions, terminology, and language, and why language matters. And we will review the numbers, the demographics. So what is a caregiver anyway? That term is used for a lot of different types of people providing care. In fact, it's used commonly in my health system at Swedish and probably UW Medicine as well. Those are more formal caregivers. We're going to focus today on family or informal caregivers. This, by definition, is any relative, partner, friend, or neighbor who has a significant personal relationship with and provides a broad range of assistance for an older person or an adult with chronic or disabling condition. Remember that the informal caregiver may be the primary or just one of a number of caregivers, and they may live with or separately from the person receiving care. We will call, just by definition, the person receiving care the care recipient, and you can see that there's this overlapping relationship. Since we are focusing on the dementia caregiver today, I'd like to review some dementia terminology. And I like the way this graphic put it, and I encourage us all to use this terminology. When we speak about a person with dementia, I recommend that we say a person or people with dementia, a person or people living with dementia, or a person or people with a diagnosis of dementia, if that's appropriate. And to really never or avoid the use of terms like suffer from dementia, afflicted from dementia, because those are judgment terms and not appropriate. Try to avoid describing somebody as demented, and certainly try to avoid slang expressions that can be derogatory, like not all there, or a few cups short of a tea set. And the hardest one for me is try to avoid calling these people patients. It is kind of ingrained in, I think, my mind through my training, I'm not sure, but I try to work on this, but let's try not to say the dementia patient, if possible. And so language matters, and so I want us to keep that in mind always. And this chart is not specific to caregivers, but more specific to geriatrics and older adults in general, and something I try to include in all of my talks because it is really just, I think, that important. And this is from an article in the American Geriatric Society by the executive director, Nancy Ludenberg, and she states, aging needs to be redefined. Widespread negative assumptions about getting old have led the public to taking a fatalistic stance that there's really just not much to do about aging. And so she makes an effort to suggest that our language matters when we talk about older adults, that when we use terms like tidal wave and tsunami, and I think if I asked you to raise your hands if you've heard that term related to our growing older adult population, I'm sure all of you have, if we use those terms, they set up a catastrophic situation. And if we instead think about affirmative language, as Americans live longer and healthier lives, for instance, this is a better approach. We could spend an entire talk trying to debate what people who are older like to be called or what we should call older adults. But she suggests that we should avoid terms like senior and elderly, which are very, very common. But because they are othering and they stoke stereotypes, and instead use more neutral language like older people or older Americans. And instead of using terms, conflict-oriented terms like struggle, battle, and fight, like we're hearing actually on a daily basis with COVID-19, right? Instead of these similar conflict-oriented words when talking about aging, we should use a building momentum metaphor, such as aging is a dynamic process that leads to new abilities and knowledge that we can share with our communities. And in fact, they did research, they did a study looking at this building metaphor, building momentum metaphor, and it actually reduced ageist attitude by a remarkable 30%, which is pretty cool. So language matters, and we should pay attention to that. So this article I found from your very own University of Washington School of Nursing in 2015, which reported on dementia-friendly, dementia-capable, and dementia-positive concepts. And I want us to keep these in mind as we focus on strength-based approach to treatment of dementia and to caring for the caregiver. We all know now that we have a significant local effort in dementia-friendly communities, and I think this is so important, not just to the person with dementia, but also their caregivers. I don't know how many of you, I hope some of you, maybe not all of you, know about Momentia. If you go to your browser afterwards and do momentiaseattle.org, you'll see a list of curated activities, physical activities, drama, art, music, and dementia cafes where people with dementia and their caregivers can go to engage in meaningful activities. And I mention here, because if you go to momentiaseattle.org now, you'll see that many of their activities are virtual, just like we are all here today. So who are the dementia caregivers? Who are they? Well, 83% of the help provided to older adults in the US comes from family members, friends, or unpaid caregivers. So these are the so-called informal caregivers. And nearly half of all of that is caregiving that is provided directly to somebody with Alzheimer's or another dementia. Most caregivers just care for one adult, but a significant minority care for two, and a small minority of 3% care for 3 or more adults. More than 16 million Americans provide unpaid care for people with Alzheimer's or other dementia. And as you might suspect, about 2/3 of dementia caregivers are women, although many might have suggested that's more. And about 30% are 65 or older themselves, and 60% or more are married, living with a partner in a long-term relationship. And so why are we here talking about this today? Why is this topic important, the dementia caregiver? Well, we know by the 2020 Alzheimer's disease facts and figures, we know that the number of people with dementia is increasing, and we expect that to increase. We know that we are actually, over the last 2 decades, getting better at treating heart disease, which is a great thing, a wonderful thing. And it means that people are living longer. And the longer you live, the higher risk you have for developing dementia. And so we now have 5 million Americans living with Alzheimer's. We expect this to grow significantly. Every geriatrics talk has a slide with this chart here, the growing number of older adults in our communities. We are, and the growing number of people that we expect with Alzheimer's dementia, up to 14 million in 2050. And the other reason that this topic is important is that there's a survey of primary care physicians appearing in this Alzheimer's fact and figures, which finds nearly 9 in 10, 87% expect to see an increase in people living with dementia during the next 5 years, but only half say that the medical profession is not prepared to meet this demand. And I would argue that is one of the reasons I am here, that I feel passionate to talk about this topic, because I feel passionate to teach about dementia. And so much of the care we give to a person with dementia focuses on caring for the caregiver. So let me introduce you to Ms. Jones and her daughter Vera. They are my patients at Swedish Family Medicine First Hill, but this is not their picture and these are not their names. They are a mother-daughter pair. Vera works in a local hospital, in fact. She leaves Ms. Jones at home during the day, and she recently cut back on her hours and thinks she may need to cut back more because Ms. Jones, who has dementia and is losing function, just starting to need more help. Ms. Jones does not want anyone else caring for her, and in fact, Vera feels like she may not be able to even hire care if she wanted to hire care for her because of her household income. She doesn't think she could afford it. So what Vera does is she puts out her food and medications for Miss Jones before she leaves for work. But there's increasing concern about leaving Miss Jones home and alone at home. And we hear this a lot. She's worried that she's not going to eat. She's worried she's not going to drink. And she's worried she's not going to take her medications. Moreover, she is increasingly worried that she may leave the house and wander. There's no other family around to help with the care. And this mother-daughter pair is a very close dyad. Miss Jones raised Vera as a single mom, and she was her single child. And they have been super close their whole life. And so when Miss Jones needed more help, there was no question that Vera was going to take her in the home. So we've talked about the dementia caregivers. We've talked about who they are. Well, let's talk about what challenges they face. And I like to call this the dimensions of dementia caregiving. I want to think a little bit about the economic dimensions. I want to think about physical health as it pertains to the caregiver, emotional health, and just this concept of distress versus rewards. First, let's think about the specific care demands of a person with dementia. You'll see that the caregiver has demands that are a balance of both physical and physical and cognitive demands that span the 4 M's, right? And focus on function. You know, by definition, when we make a diagnosis of dementia, somebody has abnormal testing on a cognitive test, has a history consistent with functional decline, right? And as the dementia progresses, by definition, the function continues to decline. First, it's the instrumental ADLs that the caregiver helps with, the shopping, the cooking, the managing medications, the transportation. And then it's the more physically demanding for the caregiver, ADLs, such as bathing, dressing, grooming, mouth care, toileting, transferring. The caregiver has to manage medical appointments, manage the continuum of behavioral changes and symptoms. We will talk a lot about this today. This is a key factor in helping care for the caregiver. The caregiver has to navigate support services. I have to say we have an abundance of support services for dementia caregivers in Seattle. We are super lucky. However, when you are working like Vera is, or when you are unable to navigate these support services, they don't do much help. And then considering transitions in care, planning for the future, managing family issues, this is a lot of care demands on a caregiver. Let's talk specifically about economic demands. We know that in 2019, caregivers of people with Alzheimer's or other dementias provided an estimated 19 billion hours of unpaid care and a contribution to the nation valued at $244 billion. And I want to emphasize $1 billion. All the while, 41% of caregivers have a household income of $50,000 or less. This is terrible. This is an area where we have absolutely failed our older adults, and we have failed the people who want to care for them. We must do better. We must find ways to provide economic support to caregivers so that care recipients, if they want to, can stay in the home. And this is something that I think as care providers for older adults, we need to continue to advocate for. We know that 69% of caregivers suffer lost wages, lost health insurance, other job benefits. We know that because they work less, their retiring, this has an impact on their retirement savings or investment Social Security benefits, and that these losses hold serious consequences for the caregiver. And we just must do better as a society to support them. Locally, you can see in the state of Washington, there are 353,000 caregivers providing $5.2 million in unpaid care. Again, we can do better. Physical health. We know that caregivers have a higher risk of many health outcomes, the adverse health outcomes. We know that dementia caregivers are more likely to have more infectious episodes, slower wound healing, increased hypertension and coronary disease. And a recent study, a meta-analysis examining the associations between caregiving, family caregiving, inflammation, and immune function suggests that dementia caregivers in particular had reductions in immune function, and elevations of elevated signs of inflammation, like pro-inflammatory cytokines. And we know, especially when we're thinking about COVID-19, we need our caregivers to have excellent immune function and excellent ability to fight off infections just because of their critical role. We know this 2017 poll showed that 27% of dementia caregivers delayed or did not do things to take care of a personal health problem. And I will say that is definitely an underrepresented number because caregivers often just don't have the time or the energy to take care of themselves. We know that. But I do want to mention that other studies suggest that caregiving tasks can have positive effect on keeping older adult caregivers more physically active than their non-caregiver, than folks that are non-caregivers. So that's something to consider and think about. From an emotional health standpoint, depression diagnosis is common in up to 50% of all caregivers, more who perform the intense caregiving that is required of progressive dementia. And it's pretty clear based on studies that behavioral symptoms of the care recipient can be the tipping point at which, prior to the caregiver is coping really well and doing just fine, but with the behavioral symptoms, this can be the point at which they just need more help. It's that tipping point. Many caregivers, when asked, 59% of people caring for Alzheimer's, people with Alzheimer's or other dementias, rated the emotional stress of caregiving as high or very high. And I just mentioned here that there is a really significant, based on some early research, spousal risk of dementia. So if you are taking care of your spouse with dementia, you as the caregiver have up to a 6 times risk of developing dementia yourself. And interestingly, this risk continues after the spouse passes away, after the spouse dies. And it's thought that this may be from an overregulated HPA axis and the effects of elevated cortisol levels. And that these are neuropathologic changes and not just circumstantial changes. So I think this is important for us to keep in mind when we are taking care of people with dementia and there is a spouse as the caregiver. But really, like my experience, there can be a lot of positive aspects of caregiving. And this article was recommended to me by a colleague, and I just really appreciated it and wanted to share it with you, because if we understand what leads to a positive experience of caregiving, we can help our caregivers try to attain that. And so positive aspects of caregiving encompassed 4 key domains in this article: personal accomplishment, mutuality in a dyadic relationship, family cohesion, personal growth, and purpose. And that positive caregiving experience is more likely to exist if these 3 conditions also exist: personal and social affirmation of the role fulfillment, effective cognitive emotional regulation, so better coping, and contexts which favor finding meaning in the caregiver experience. So keep these things in mind. And so now we've thought about the dimensions of care that caregivers face when taking care of a person with dementia. I want to mention the validated tools that are used to assess caregivers in a clinical setting. Well, there are lots of caregiver assessment tools, and you can choose your favorite among many, but these are 2 of mine, the Caregiver Self-Assessment Questionnaire and the Zreet Burden Interview. And in a clinical setting, like any good tool, these assessment tools prompt us to ask the right questions. And I want to urge you to remember that the provider who treats the care recipient themselves, the person with dementia, is often the first healthcare professional to detect strain or burden because of the dynamics in the caregiver-care recipient dyad. And even then, indications of need and opportunities to prevent distress mandate us, absolutely mandate us, to routinely screen screen the caregiver and how the caregiver is doing in their caregiver experience. And so please, please, please keep this in mind. And so let's talk about Vera and Ms. Jones and the dimensions of the caregiving that Vera is providing. I already mentioned the economic stress, her decreasing ability to work, as Miss Jones has increasing care needs. Well, in terms of physical health, I can tell you, because I'm Vera's physician as well, she has hypertension and dementia. They're both pretty well controlled. And I do wonder if she was predisposed to these conditions potentially by the cortisol and inflammatory responses related to the caregiving that she was providing, or maybe at least in part. In terms of her emotional health, Vera has a strong faith community for which she draws a lot of support. She does not have a documented mental health history of her own, and she is open to resources. And I've seen this in my own practice, that people who are open to resources, caregivers that are open to resources, often have just sort of correlated, in my experience, with better emotional health. But still, even though she's open to resources, she has not found it easy to connect to them. When thinking about the distress versus rewards, you know, like I said, Vera and Miss Jones have always been very close. Miss Jones was a single mom who cared for and loved Vera fiercely. They really have been each other's very best friends, and so such a close relationship, a lot of cohesion. And Vera often, even as Miss Jones was declining in function, and even after they were able to sort of not able to have as much of an emotionally close connection, Vera was able to articulate a sense of purpose and fulfillment in the care. And so we have talked about who are the dementia caregivers. We've talked about what challenges they face. Next, we're going to talk about how we support dementia caregivers on each step of the caregiver journey. But before we do that, we are going to take a little break. We are going to go through a meditation that you can find online and share, because it is intended actually for family caregivers. Now, because of the wonders of Zoom webinar, I am going to allow you to participate if you'd like, or to turn your volume down and just take a big stretch, go for a little walk. And after this 5-minute meditation, we will continue the talk.
Deep breathing. Breathing deeply is a quick way to relax. You can do it almost any place and time you need to relieve stress. Deep breathing helps maintain a sense of calm, and it's part of almost all relaxation and meditation techniques. The key is to breathe deeply from your abdomen rather than shallowly from your lungs, and get as much fresh air and oxygen into your lungs as possible. Begin by sitting or lying down in a comfortable position. Close your eyes softly. Put one hand on your stomach and the other on your chest if possible. Feel your breathing for a short time, noticing the rise and fall of your stomach. Breathe in. Inhale deeply through your nose. As you breathe in, the hand on your stomach should rise, and the one on your chest should move very little. Breathe out. Exhale through your mouth. Push out as much air as you can and feel your stomach tighten as it flattens. Again, the hand on your stomach should move, but your chest shouldn't move much. Be sure that you empty out all the air and then pause. Try to inhale to the count of 10. And then exhale to the count of 10. This helps to slow your breathing. Repeat this breathing for several minutes. If you're lying down, you can put a small book on your stomach and try to breathe so that it rises when you inhale and falls when you exhale.
Okay, now that we're all sufficiently relaxed, you can remember that as a tool, both for you if you feel stressed by giving care in our formal caregiver way to people with dementia, but also sharing with the caregivers that we take care of as well. So we're going to move on to the third part of my presentation, which is supporting caregivers along the caregiver dementia care journey. We're going to talk starting with a diagnosis of dementia and ending with end of life and grieving. And I put a picture on the left of the Dementia Roadmap, which is a guide for family and care partners. And if you remember nothing else from this talk today, I encourage you to get your hands, if you haven't seen it already, on this Dementia Roadmap. It is available in both paper form by way of an email. You can email this link on the Dementia Action Collaborative website. It's also available online, but it's just so much more effective to use in person. And I share this with all of the people that I take care of with a new diagnosis of dementia and their caregivers, or if I'm meeting somebody for the first time. It is an incredible resource, and it was developed by the Dementia Action Collaborative, which was established in 2016 and is a group of public-private partners committed to preparing Washington State for the growth of the dementia population. I love the cover. You know, it's beautiful and hopeful and consistent with, you know, what I try, which is a strength-based approach to dementia. And the Dementia Action Collaborative, in addition to this roadmap, the website has lots of tools and lots of resources that I encourage you to check out. So if you remember nothing else, I want you to make sure that you know about this resource. So the first step of our journey in dementia caregiving is a diagnosis of dementia. And the key point I want to share with you today, if you don't already know, is that research has shown us, we know this to be true, that fewer than half of Medicare beneficiaries who have a diagnosis of Alzheimer's or another dementia in their billing records actually report that they have this diagnosis. So they have never been told. And that is not just the dementia, person with dementia, him or herself, but it's also the caregiver. And so that even if we know a person to have dementia, we don't always, by this data, tell people. And I think this is a really, really important point. And I think we can do better, and I think we must do better. And I'll share a couple diagnosis stories from the dementia facts and Alzheimer's facts and figures from this year that I think illustrate why this is so important. First is a woman by the name of Cynthia, who is living with Alzheimer's disease. She described the challenges she faced after beginning to experience symptoms at age 50. Her symptoms negatively affected her ability to conduct her work as a pastor at a busy Presbyterian church. The process of pursuing a diagnosis itself was very challenging. Multiple referrals to specialists and tests, not all of which was covered by insurance, so it was very expensive. And it took 8 years from the onset of symptoms to the time she actually received a diagnosis. And she says that when she finally received the diagnosis, she felt relieved. And not all people feel that way when they get a diagnosis, that's for sure. But she felt robbed of years of her life where she was worrying about what was wrong with her and not having access to support. And so I think that's just one example of why making a diagnosis is so important. The next is a woman by the name of Marie. She cared for her mother with dementia, who was diagnosed in 2017, and she echoed Cynthia's remark by saying there was a long lag time between the onset of symptoms and the diagnosis of dementia, and that was 5 to 7 years for her mom after she noticed changes. And she reflected and observed a reluctance among healthcare providers to even engage in talking about the cognitive changes. And she wondered why. She wondered whether it was that people weren't trained to do so or they didn't have time, but she just noticed that people just avoided it. And she felt, again, that she lost support. She lost support that she could have then been a better caregiver for her mother those years. Another interesting issue that Marie raised was a cultural one as it pertains to diagnosis and treatment of dementia. Speaking from her experience from a Latinx community and an immigrant family, she noted that many in the immigrant community, for many, there is a shame and stigma that comes with the loss of ability and independence on the part of older adults. More so, there's an expectation that the care will be provided and maintained strictly within the family unit. And when people like Marie needed help from the outside, caregivers themselves can experience shame and stigma. And so we want to think about this. Marie suggested that there should be the establishment of Alzheimer's navigators, professionals who are trained to serve as liaisons who can guide persons living with dementia and care partners through what she quoted, the maze and the haze. And I think this is an excellent point. I think it's one that all of our health systems strive for, and that some of the really innovative care programs that I'll mention for people with dementia and their caregivers really do well. Because from the time of diagnosis, we can do so much more to integrate clinical care with community-based support. And you'll notice in the bottom right, our first resource that hopefully everybody knows about, and I challenge you to refer 5 patients in the next few months to the Alzheimer's Association because they are underutilized. They have a tremendous amount of resources, not only for persons with dementia, but also for caregivers. And those resources can be online, as is important these days, in person when we begin to gather again, and quite hands-on, as I'll mention in a bit. And so we've made a diagnosis, and hopefully I have convinced you that making a diagnosis of dementia is important, but it doesn't end there. We can't send people on their way with a follow-up, card with their next visit 3 to 6 months down the road. We must actively manage people with dementia and actively support their caregivers. And so how do we do that? Well, here are a list, some lists that come from the Dementia Roadmap. And I'm going to go through them because at each stage, there are really common questions that caregivers have. And if we can be prepared to answer those questions and to share and educate with our caregivers, we can do right by them. And so first, are there any medications, treatments, or lifestyle changes that could help my loved one's memory and thinking, the caregiver might ask? And of course, we would love to have that magic pill. We would love to be able to reverse the course of dementia. We don't have that, we can't do that. But we can do a lot of things. And firstly, we know that people with cardiovascular risk factors that are well managed, that have a decreased risk of heart attack and stroke and well-managed diabetes and hypertension are less likely to have progressive changes in dementia at a rate at which those who are not well-managed do. So what I'm trying to say is that the heart healthy focus, a focus of care that addresses cardiovascular risk factors can help prevent dementia, we believe, when done right, but even more importantly, slow the course of the disease. So we need to keep that in mind as we recommend heart-healthy diets, as we recommend managing medical problems and chronic diseases. The people with dementia who are diagnosed and their caregivers will probably ask about the medications we have specifically to treat dementia. And there are medications. We have medications like cholinesterase inhibitors and NMDA agonists. And these medications can help a little bit, some people, some of the time, but do not change the course of the disease. And it's ethically important, I believe, to talk about these medications, to offer these medications when we make a diagnosis of dementia. But we need to be sure that we manage the expectations of the person with dementia and the caregivers, that we look for real side effects that can come from these medications, and that we continue to balance risk versus benefit. How can we help our loved ones stay active and connected, a caregiver might ask? Well, engaging in community activities like ones that you might find at momentiaseattle.org is just one way. We can consider encouraging, but really most importantly, you'll see down in the left-hand corner, our beacon, the 4 M's. Think about what matters most to this person. Think about how we can help them engage in activities that matter most. Should my loved one still be driving? This is such a difficult issue because it balances safety and autonomy. And we want to give our person with dementia as much autonomy as they can have. We know that not everybody in the early stages of dementia is unsafe to drive, but many are. And I believe it's critically important for the healthcare provider to take the role of assessing and counseling older drivers, to take the burden off of the caregiver to make that decision, and to begin early and often talking about driving retirement. You notice I'm not saying take away the keys or giving up driving. Talk about driving retirement. Talk about what life would look like if a person stops driving. And I have to say, this is one of the toughest things in managing and helping caregivers. And I've actually had a patient or two stop coming to see me because I've told them that it's important that they stop driving after I do a thoughtful and careful evaluation, but that's okay. We need to be doing right. We need to be making these assessments and getting help if we can't make these assessments through our neuropsychology partners and through our driving rehab specialists. And finally, in early stage dementia, we need to start thinking about advanced care planning. We need to think about legal paperwork in place. It is so important to do this in the early stages of dementia when a person with dementia can still say what they want. This is so important. We need to think about financial issues. We need to think about issues related to identifying a health proxy. We need to think about issues about the type of care people would want as they progress in dementia. And more commonly these days, you'll see dementia-specific directives. And while I won't go into detail, you should know that they exist. You should know that they're a bit controversial, but that they're important. And we should be thinking about this with our patients who have dementia. So early and often, advanced care planning. You'll see Prepare for Your Care is just one of a myriad of amazing resources that you can share with a person with dementia and their caregiver to start having the conversations about advanced care planning. So moving on to mid-stage dementia, this is the stage where we begin to have more of a focus on safety. This is a stage where behavioral and psychological neuropsychiatric symptoms can commonly present. And as I mentioned, these can be predictive of burden and strain, and finding supports for these very specifically is important. And so what can I do to make the home safer? Well, it turns out that the Alzheimer's Association has a care consultation program where they'll actually send folks out to the home to assess for care needs, to help coach the caregiver, and to have a really great home assessment. We can use our home OTPT partners to do home safety assessments and to think about making the house as safe as possible. Resources such as our area of agencies on aging, locally community living connections, can help think about what type of resources a person with dementia might be eligible for. This is a stage where we might need to revisit the issues of driving retirement. And I have a whole nother talk on that topic. If you're interested in hearing more, I'd be happy to share. And we need to think about getting help for coping with dementia behaviors. This is where a lot of the innovative care models for people with dementia come into play, because they focus on giving care to the caregiving and the person dyad, and specific caregiver specific information in terms of coping with behaviors. And I'll share a little bit about that more as I go on. And once again, this is a place where our interprofessional teams are critical to outreach and to connect with our caregivers from our clinic-based settings. And once again, this is a stage where we need to start thinking about the future. We need to make sure and revisit our advanced care planning. And so as we move towards later stage dementia, we need to think about care setting. We need to think about how we promote quality of life. And maybe most importantly, we need to think about what quality of life looks like for the person with dementia, and also for the caregiver. We need to think about whether or not we need to bring help to the home, in which case we need to think about the cost. And like I mentioned earlier, the cost of care for people with dementia is really considerable. And I just posted here on this slide what you could expect an average of cost for each service. And if you are just not quite low income enough to qualify for Medicaid, these costs are just insurmountable, and an area, again, that we need a lot of advocacy. So how, in terms of other things that we want to think about in terms of supporting caregivers in later stage dementia, medication deprescribing. So as a geriatrician, I love to deprescribe. It's literally one of my most fun tasks when I take care of people, is to think about what medications I can deprescribe. And it is always important for older adults. It's always important in dementia, but it's never more important than as the dementia progresses, because more pills can not only cause more side effects, but they can be a burden even just swallowing them or paying for them. And there's been research. I encourage you to look at deprescribing.org if you're not familiar with that website, deprescribing.org. They've done some research into dementia deprescribing, and they've found that most people with dementia and most dementia caregivers are very open to and very grateful when their care provider recommends stopping medications. And so it is, it's important to keep in mind front and center, especially as dementia progresses. Respite care, this is a stage often when the physical demands of caregiving become really high, and that sometimes people just need a break. And I'll mention that in the next slide. And once again, advanced care planning. We need to coach our persons with dementia and their caregivers about what to expect as a person with dementia gets to the end of their life. We know that people with dementia die from infections and feeding problems often, not always. And we need to prepare the caregiver for this, and we need to have a plan in place if the person stops eating, person stops drinking, or they have a severe infection. Respite care is underutilized and sometimes hard to find for people, but really important to know about when you're caring for people with dementia, and really important to recommend for caregivers. By definition, respite care is a service where another trained person or staff at a facility provide planned short-term care, a few hours to a few days, for a person who needs help, allowing the caregiver some time away. And locally, the Family Caregiver Support Program and the King County Caregiver Support Network administer this program through Community Living Connections. And so I think you all have the slides, and so you can investigate this if it comes up for people that you take care of. So as we move towards the end of life in the caregiving journey, we need to think about what setting is desired and practical. You know, in the last 20 years, the proportion of individuals with Alzheimer's who died in a nursing home decreased considerably, 68 to 51%. And the portion who died in a medical facility decreased considerably as well, 15 to 5%. And this is most likely because of the uptake of hospice for the dementia diagnosis. And as much as I am a huge fan of hospice, really I don't know what I would do in my practice without them. We need to remember that hospice doesn't mean 24-hour care, and the person with dementia still needs 24-hour care by a care provider as they get to the end of life. And the family members still need that coaching about how to use medications. This is a great place where hospice can come into play, and preparing for grieving. We need to remember that in the end of life for Alzheimer's or other dementia, this period of time can last a long time. This may be as opposed to cancer or heart disease or COPD. This end of life can last, I've seen it last years when we think somebody may be coming to the end of their life, especially if they continue to eat and drink. And so the intensive supports that we provide along the caregiver journey need to be in place for a long period of time. So when we get to discussing the grief of a dementia caregiver, it's important that we don't assume that the person with dementia, the caregiver of the person with dementia just feels relief, of course, after their loved one dies. But they, despite the fact that they may have a long time to prepare for the death, there is often considerable grief, and we just need to think about that. And this study, just recently out of the University of Utah, talked about positive and negative grief experiences and sort of what went into them. And so if we think about these aspects of positive and negative grief experiences, I think we can try to set, as much as we can, set our caregivers up for a positive grief experience if possible. And I don't want to make it sound like it's all on us to do that, but I think thinking about the things that go into grief experience is important. And so positive grief experiences in this study included those that had positive construction of memories of the person who died. Thinking of death as the end of suffering led to a positive grief experience, and having relationship resolution. And negative grief experiences included a situation where a family member's decline was seen as very traumatic, where there was a big loss from the caregiver of their role as a caregiver, where there was unavailable support for the caregiver. And I put that star just because this is where we can help. This is where we can make a difference. And then a negative grief experience was also noted when the caregiver just couldn't imagine creating a new life that was outside of caregiving. And so let's move towards talking about model programs and concepts to provide support to dementia caregivers on their caregiving journey. And I want to come back to an emphasis on strength-based approaches. I really like this visual here. This is the concept of person-centered care delivery. And again, see that individual with dementia and their caregivers right at the center? Well, this sort of urges us to consider and to design care for people with dementia by moving away from an approach that focuses on the loss of abilities, so de-emphasizes what they can't do, and emphasizes the individual's unique needs, personal experiences, and strengths. And I think I've read about people with dementia who may have otherwise not been very artistic, that as their dementia progresses, they actually become more and more artistic. And I think about that, and the suggestion is really that maybe they had these parts of themselves that sort of didn't allow them, that put up sort of this like, oh, I'm not a creative person type of thing, and that when they progress in their dementia, they let their guard down and they really become very creative and artistic. And so I think it's really important to think about these things and to suggest them and support them. And so we're going to talk about two very specific model programs for persons with dementia and their caregivers. And the first is the UCLA Alzheimer's and Dementia Care Program. Out of UCLA, Dr. David Rubin is sort of this leader in geriatrics that leads this program. And I'll just mention before I get the video started that Alzheimer's and dementia care videos to train caregivers on all of these issues that you see on the left of the slide, all of the things that we talked about that make caregiving for people with dementia so hard. There are videos, short videos that you can share either in the exam room with the caregiver or send them links to these caregiver training videos. And I think this is just a key tool that we can have. But I want you to listen about the UCLA Alzheimer's and Dementia Care Program.
I always joke with my mom, like, I wish I had your health care because you have great care. To be able to come in and for my mom to be surrounded by people that genuinely care about her is an important thing.
The UCLA Alzheimer's and Dementia Care Program is a co-management program in which a nurse practitioner works with the patient and their family members as a dyad and works with the primary care physicians to provide care for dementia, Alzheimer's disease on an ongoing basis.
Whatever their needs are, we try to meet them where they are and guide them through this journey. Our method of communication is not limited to the office setting or to having to schedule an appointment. We're available by telephone during business hours, by email, which really helps to enhance patients' access to healthcare.
She took a minute to have me go through some questions and answer questions about my being a caregiver. It was a really good feeling to know that I had someone in my corner. She initially just got me on board with everything, all the things that I knew I had to do, but I couldn't tackle it on my own. I think I would just be a frustrated mess without Janine in the program. And I don't think my mother would be as happy. She truly is a happier person because of it.
This program fills that unmet need of coordinating care, but also making sure that the caregivers are adequately prepared for the journey of this disease. The dementia care managers are the shepherds, the guides, the coordinators, the advocates. They are the go-to person for patients and the families.
I refer patients to the program because caregiving for a patient with dementia is challenging, and the program helps meet the needs of both the patient as well as the family members and caregivers who are struggling with managing to take care of these patients.
Every person who has dementia and their families go through a journey. And the purpose of this program is to make that journey as dignified and as smooth as possible.
My favorite part about the job is the relationships that we build with the patient and their family, and it's nice to be able to offer them some kind of hope and let them know they're not alone.
What I'm learning now to do is to try to care for myself so that I could care for my mom, because I'm in a happier place and able to assist my mom. My mom feeds off that energy and is a happier person.
Really great program. So the next program I want to talk about is something called the Dementia Care Ecosystem. And this was developed out of UCSF and is now in multiple sites, actually across the country. There was an article published just in September of this year that showed that the dementia care ecosystem improved quality of life for a person with dementia, reduced emergency room visits, and decreased caregiver depression. So this is a really great program as well. And the difference or the unique aspect of this program is that you have a patient caregiver dyad, and the person who is their go-to is actually somebody called a care team navigator. And as opposed to that being a nurse practitioner specialized in dementia, this is actually a trained lay person. And when I heard about this program, they actually said that it's a lot of college students who are taking a year off before professional degrees, and that these college students then would go on to careers with older adults, which I just thought was so amazing. And so let me allow the video to speak for itself, an introduction to the dementia care ecosystem.
I was in a meeting at the University of California, San Francisco, when the staff who had designed the program called the Care Ecosystem announced it. I remember tearing up and saying, "Dear God, it's the answer to all my prayers."
The team that developed the Care Ecosystem, including myself, we work at an academic medical center where we have a lot of dementia specialists and we're able to provide really good dementia care. We wanted to design a model of care that could reach patients with dementia wherever they live.
Within healthcare systems, there are people with dementia and their caregivers who are kind of floating out there without the support that they need.
For most patients who have dementia, they receive their diagnosis from primary care. Maybe they see a neurologist. But for the most part, they're left on their own as they try to navigate the challenges of dementia.
Research has shown that primary care providers actually don't feel confident and they don't feel like they have the time to really adequately address the problems that come up with dementia, the issues that come up.
When my father was first diagnosed with a dementia, we got nothing outside of the diagnosis. There wasn't a leaflet that said, "Here's the description of your disease." There wasn't a social worker. There wasn't a clinical nurse. There was nobody. We were given a diagnosis and sent home.
The lack of understanding of some symptoms of dementia might lead families to take their loved ones to the emergency room, not recognizing that a particular symptom is part of the diagnosis that they've already received. Or even when they do recognize it, they may not know how to diffuse the situation or manage that particular symptom.
To be able to have an access point to direct response on critical symptom management is beyond huge. It certainly kept my family out of the emergency room more than once.
The majority of the burdens in dementia are carried by the caregivers. These are usually members of the family, someone who loves the person with dementia. This is that workforce in dementia. We need them. They are the only workforce of sufficient size and distribution to manage dementia. But they didn't sign up for this role. They were not trained to take on this role. They have many other responsibilities. They may still work, for example. And we have a responsibility as our society to help those caregivers, to usher them into this role and support them as they take on the evolving challenges.
Really, another really amazing program that I hope actually comes to our local area someday. The Dementia Care Ecosystem has an amazing area of resources that are open access to all of you and me. You just can search the Care Ecosystem and it comes up. And not only do they have all of these resources on caregiver well-being, on safety, end-of-life care, decision-making, medications, but they have all of these resources in Spanish and Cantonese as well, which is truly amazing. So what do we have locally? Well, I just want to give a shout out to the UW Medicine Memory and Brain Wellness Center, a truly state-of-the-art interprofessional service that takes care of people with Alzheimer's and other dementias in very, very expert ways within a tremendously devoted care team and lots of amazing research that goes on there. At Swedish, I run an interprofessional geriatric assessment clinic. As Barb told you early on, we have an interprofessional care team that you can see here. We actually do very specific interventions for people, for caregivers, during the time that the caregiving recipient is getting a cognitive assessment, when we would naturally separate them as well. And I think providing care to the caregiver during a care recipient's appointment is such a great opportunity that I would encourage others to think about. And this, everyone has their favorite COVID Zoom picture. This is one of my favorites. It's a candid shot, but it is our interprofessional team of pharmacy, social work, behavioral health, and geriatrics, providing these geriatric assessments by way of Zoom video to patients, to persons with dementia and their caregivers. And we're doing this by video if they have the ability to do so, but we're also doing this telephonically. And it's been, I think, provided a great opportunity for learning for our team, but I think great care in a time where there's no way we could give enough support to people who are giving care for loved ones with dementia in the time of COVID-19. This article I encourage you to read, When Dementia Meets the Coronavirus Crisis, and these are just some considerations, I think, for dementia caregiving during this time. Outreach, outreach, outreach. The caregiver and the person with dementia are going to assume you're too busy, and so they're probably not going to reach out. So we need to reach out to them. We need to check in about how they're doing. We need to educate them about telehealth. We need to educate them about the virus itself and how to stay as safe as possible by limiting exposure to not just the person with dementia, but also the caregiver. To set up backup caregiving, which is always an important thing, but maybe never more important than now. We need to think about having specific advanced care planning discussions that are different in the time of COVID. And we could have a whole talk about advocacy for being present if a person with dementia is hospitalized these days. But I heard it said this way, that caregivers for persons with dementia, when they get admitted to the hospital for whatever reason, should be thought of as essential staff. Should be thought of as essential staff and not prohibited from visiting because of concerns of the virus. And so we need to advocate for these things. People of color and other marginalized populations have experienced racism over time. Racism has a long history, particularly in the African American community, and is a unique stressor to African American caregivers, especially related to trust building. And so we must tailor caregiver interventions to mediate stressors, resources, and coping strategies based on caregiver preferences. And so this article, recent article that was titled "Walk a Mile in My Shoes, an African American Caregiver's Perception of Caregiving and Self-Care," suggests that support from family and friends is associated with better self-rated health for African American dementia caregivers. So we need to keep that in mind when we take care of people with dementia and caregivers who are part of the African American community. And so Vera ended up leaving her job at the hospital so that she could provide 24/7 care for Miss Jones. She cared for her full-time for about a year before her death. And during that time, Vera actually faced a health crisis of her own. She had severe acute low back pain that brought her to the hospital for overnight. And we were able to get some respite care for Miss Jones, which was great. And then Vera went back to her 24/7 caregiving job. Hospice became involved. Hospice provided great support. Vera and the hospice nurse developed a really neat, wonderful relationship that I think helped. And as Miss Jones moved towards the end of her life, she was able to stay at home, and she died fairly peacefully at home with a lot of coaching by the hospice nurse, and hopefully she felt support by me and my team as well. And even though Vera had a long, long time to plan for her mom's death and to grieve, the profound nature of her grief at the time of her death, I will never forget, was really, really meaningful to me. And just goes to, I think, emphasize how we need to support folks, not just at the time of death, but then afterwards through the grief process. And so hopefully we've answered these questions. Who are the dementia caregivers? What challenges do they face? And how do we support dementia caregivers through their caregiving journey? And while we don't have disease-modifying treatments yet for dementia, our collective role as an interprofessional team treating a person with dementia and their caregiver is absolutely critical. Resources are plentiful. This dementia roadmap from the Dementia Action Collaborative is really my go-to resource to hand to all dementia caregivers. And with that, I thank you very much. Again, a picture here of my brother and I. My brother is a physical therapist, and he would absolutely say that he is in his role because of Grandma Ann as well. With that, I will take questions.
Great. Thank you so much, Carrie. This was just magnificent. I have a series of questions that came up about driving, so I'm going to post them somewhat together. Wendy says, thank you so much for saying that it is a physician's role to assess patients for driving. She sees all too many families tasked with this, and it detrimentally affects the family relationships. More physicians should be discussing driving at every visit. And there's a question about, are there resources in the Seattle area to do, or other areas, because we're expanding across the Northwest region, to do formal driving assessment?
Really good question. You know, we try to do that as one of the resources that are in a professional geriatric assessment clinic, but and so other places like our setting, and if anybody knows about the Memory and Brain Wellness Center at UW Medicine Harborview, I would be interested to hear if that is something that they do. But one of the places that is sort of gold standard, or one of the resources that's gold standard for this, is something called a driving rehab evaluation, and that's done by specialist occupational therapists. And this is a resource that is available in our community, but somewhat hard to find and can be expensive. So what I found is sometimes when you're offering this service or recommending this service, if you don't feel personally that you can make this evaluation, and you tell them that it might cost them $300 or $400 or more, that's not likely that they're going to do it for a variety of reasons. But I believe that some of these places are covered by Medicare, and navigating that can be difficult.
So another question related to driving is, are Washington providers, or if you know of in other states, mandated to or prohibited from medically ordering cessation of driving?
We are not mandatory reporters for driving driving retirement in the state of Washington, but we can report, so we're not prohibited. But if we report, we are not. It is not anonymous.
Okay, and then a question about, do providers' offices have advanced planning forms there, and do they have somebody within the practice to assist with completing the forms?
I would say most primary care offices have forms available. Most don't have dedicated folks that are going to help. In some places, social workers can help, but oftentimes this is a role that is left to the care provider, and there are some great novel approaches that have facilitators coming in to help. And in fact, we're trying to think about how to implement a group advanced care planning group visit at our clinic. So that, more to come on that. But the reason why advanced care planning completion is much less than we would like is because it takes time. At least part of it absolutely needs to be done by the healthcare provider, especially when talking about very specific care wishes at the end of life. But this is still a tough nut to crack. And more importantly, like, one of the most difficult things about this topic is there are just an abundance of different resources that can be available to people.
And then back to the driving issue, a question about how do you advise the patient to stop driving? I assume that careful word choice is necessary. And I just wanted to mention there is a lecture on our website focused completely on driving by Dr. Rhodes. So you probably know him.
Oh, yeah.
But I'll let you sort of offer the quick answer to that question.
Sorry, can you just rephrase the question one more time, Barb?
Yeah, it's how do you advise a patient to stop driving?
Yeah, so Chris Rhodes is an absolute expert on this issue, but I think the key is to bring it up early and to speak about it again, and not sort of negative terms, and to oftentimes when we bring it up, we'll notice that people have already changed their driving habits, so they're driving less or driving shorter distances or not driving at night. So they're already self sort of titrating off of driving, and it really just depends on the person's situation. And it may be a situation where they may still be able to drive, but only under certain circumstances, and actually driving rehab specialists will designate exactly what those are if a person does go and see them. And of course, the driving rehab specialist, who's usually a specialized occupational therapist, actually goes on the road with folks, and so they can have very specific recommendations into this type of driving is okay and this type of driving is not okay at this time. Of course, I don't have that ability to have somebody in the car with me when I'm making recommendations, which makes them more difficult.
Okay, another question is how best to approach a caregiver who's struggling with caregiver stress and burden and maybe struggling themselves, but will not accept resources or support or doesn't want anyone else helping to care for their loved one.
That's really difficult. I think, you know, offering but not pushing resources and sort of gaining the trust of the caregiver who's not open to the resources is probably the most important thing. And so walking alongside them and listening, I think if we all had more time, we would all be better listeners. But if we can listen as to what the challenges are, provide resources but not push them, and then I think be non-judgmental supporters, I think that can go a long way.
And are there specific things that you'd advise caregivers when caring for older adults with different types of dementia? In other words, maybe different types of advice depending on the type of dementia for caregivers?
It's a really good question, and probably don't have the time to go into all of it. But I think it's a good point, and the point is that you need to see what, because everybody, even if it's just Alzheimer's dementia that you're dealing with, every person is going to have different symptoms or different course of their disease. And so the caregivers dealing with different things for different people at different times. And I think probably the same goes for, you know, frontotemporal dementia or Lewy body dementia. I think frontotemporal dementia can be particularly difficult on the caregiver because of the personality changes and because of that so early on in the disease, the human that they are caring for, the loved one, is just not the same person. And they can sort of characteristically or commonly make remarks or sort of be embarrassing to be with out in public. And so I think that's just something to, I guess, understand, particularly about frontotemporal dementia, but certainly that's a really good question.
So Linda mentions that she thought for years a navigator should be assigned when there's a diagnosis of dementia, and she's wondering how challenging was this to implement and how is it paid for? So
talking about the specifically the dementia care ecosystem, perhaps?
Yeah.
That's the one where the care team navigator
component.
Sorry, say again?
That has a navigator component?
Yeah. Well, I actually don't know exactly how the care ecosystem was funded, but I think it was funded through grants and research funding initially. And I think what we are all hoping is that we continue to see good data specifically about resource utilization, and that we can then talk to our insurers, Medicare or other managed Medicare programs or other private insurers to say, hey, this is worth it. We are, in fact, going to assign a dementia care team navigator to a person at their diagnosis and the caregiver, not only because it's the right thing to do and it makes sense from a clinical standpoint and a support standpoint, but also because it makes economic sense. If we can keep these folks out of the emergency room, decrease resource utilization, and increase the amount of care that can be given at home.
So Mary Pat O'Leary mentions, first she says it's a fantastic presentation and she appreciated the outline of phrases and concepts to avoid, including the suffering from dementia. She also mentioned that from listening to community members, they don't like to hear that professionals are asking the caregiver burden survey.
Mm-hmm. Yeah, and did you notice when I even shared those couple surveys, I tried to avoid using the term burden. Of course, the Zuri burden interview has burden in it, but I try to avoid that language as well. Mary Pat, I think it's a great point and a good reminder. If we can talk about the caregiver experience as opposed to caregiver stress or caregiver burden or caregiver burnout, even worse, I think that's really, really important.
And I'm not sure specifically if this was just a chat into you, but Donna Forrest mentions that regarding the group ACP at clinic, do you know Hillary Lum at University Hospital in Denver who pioneered these group sessions?
Oh, cool. I actually know her name. And I was on a Zoom meeting with some other geriatricians yesterday when her name came up, actually, in terms of a paper that we're thinking about writing, not on that topic, but I guess I need to get to know her for a number of reasons.
So I'll send you that information if you don't see it. And then other people are just contributing resources into the chat box and a lot of praise for an outstanding presentation. I don't see any other questions, however. Let me just check through. It's been a busy chat box here. A lot of information, enjoyable to listen to. Thanks again.
Great. Well, really, it's been my pleasure and honor, and I appreciate being invited, Barb, to come.
Thanks so much. Really appreciate it. And let me see if this is a question. Now, just more praise for the value of this presentation. So thanks so much, Dr. Rubenstein, and I will close out the meeting.
Thanks so much. Take care, everybody.